Hello everyone. I am Dr. Carrie Minnaar from Johannesburg, and I will be discussing our observation of the Abscopal Effect in our phase 3 randomized controlled trial on the use of chemoradiotherapy with or without modulated electrohypothermia. The trial was conducted on HIV positive and negative locally advanced cervical cancer patients in Johannesburg in a public hospital. Okay, the authors do not have any conflicts to declare. Right, the Abscopal Effect. The Abscopal Effect is a systemic response to ionizing radiation that results in the response and even the resolution of lesions distant to the primary treatment site. The Abscopal Effect, first described in 1953 by R.H. Mole, is rare, with only a handful of cases published annually. Our understanding of the Abscopal Effect is largely derived from in vivo murine studies. This response to radiation outside of the treatment field is believed to result from the activation of underlying immune mechanisms. This is corroborated by the increased frequency of the Abscopal Effect observed in immunogenic tumors, or tumors that are more easily recognized by the immune system, such as renal cell carcinoma. Okay, it's further corroborated by murine studies such as Shankarand's study, in which tumors derived from immune competent mice developed in almost 100% of immune deficient mice, while only around 50% of tumors that were derived from immune deficient mice grew in immune competent mice. The mechanism behind the Abscopal Effect is likely triggered by immunogenic cell death as a result of ionizing radiation. This process involves the release of damage-associated molecular patterns, or DAMPs, from cells which are undergoing apoptosis into the tumor microenvironment. DAMPs can also be expressed on the cell surface. So examples of DAMPs include calreticulin, HMGB1, and extracellular ATP. For example, calreticulin on the cell surface stimulates the dendritic cells, and HMGB1 is a pro-inflammatory mediator which is released during late apoptosis. HMGB1 also binds to the TLR4 on dendritic cells, and this prevents the accelerated degradation of the antigens within the dendritic cells. Okay. Once the stimulated dendritic cells take up the apoptotic bodies, the antigens are processed and presented to the naive T cells. This in turn induces an immune response, and it involves the CD4 and CD8 T cells, T lymphocytes. Now, this process can be amplified at various stages. For example, one could enhance phagocytosis, enhance the recognition of apoptotic debris, or enhance the maturation of the dendritic cells. This diagram suggests the use of molecules to enhance immunogenic cell death. Okay. In 2019, we reported on local disease control in our study, in our ongoing randomized controlled study, in which 202 participants were included in the analysis. Of the 202 participants, 171 were alive at 6 months post-treatment. That was 87% in the mEHT group and 82% in the control group. Okay, all participants for this study were staged clinically with a physical examination, pelvic ultrasound, and chest x-rays. Stages 2B to 3B patients were included, and patients with bilateral hydronephrosis and renal dysfunction were excluded from the study. HIV positive patients were included provided they had a CD4 count above 200 or they had been on antiretroviral therapy for more than 6 months. Okay. Participants were all planned to receive 50 grays of external beam radiation in 25 fractions to the whole pelvis. We used a 2D box technique for planning, and the superior border of the anterior posterior and posterior anterior borders was the mid L5. Okay, participants were also planned to receive 24 grays of high dose rate brachytherapy administered in 3 fractions. Cisplatin was prescribed at a dose of 80 milligrams per meter squared, administered 2 days apart. And modulated electrohypothermia was administered with the EHY 2000 at 130 watts for 55 minutes per treatment. mEHT was administered twice per week, and external beam radiation was administered within 30 minutes of completing the mEHT. Okay, all participants had pre and post treatment PET-CT scans to evaluate the disease. But as the PET-CT scans were not part of the standard workup at the facility, the disease stage was not changed based on the scans, unless there were visceral metastases or bilateral hydronephrosis was observed, as these necessitated a change in the treatment regimen. So the participants who received mEHT, as you can see in this graph, had a significantly higher local disease control than the control patients. It was 46% versus 24%, which is almost a doubling in the local disease control. When looking at the participants who survived for 6 months post-treatment, the participants who received mEHT were also significantly more likely to achieve 6 months local disease control, as you can see here. So during this analysis, it was observed that some of the participants with had extrapelvic nodal disease present on the pre-treatment PET-CT studies, and that some of these participants showed complete metabolic resolution of all disease outside the treatment field on the post-treatment PET-CT studies. So these results prompted a further analysis with the aim of comparing the systemic disease response, as seen on the PET-CT studies, between participants who received mEHT and the control participants. At the time of this analysis, all participants were a minimum of 6 months post-treatment. Participants were eligible for this particular analysis, provided they met all the trial eligibility criteria, provided they had extrapelvic nodal disease visible on the pre-treatment PET-CT, and provided they had a post-treatment PET-CT. For the purpose of this analysis, the SUV cutoff was 2.5. Okay, then the nodes were grouped by region into the head and neck, thorax, abdomen, and pelvis. The abdomen included the upper pelvis outside of the radiation field, and the pelvis contained only the portion within the radiation field. Then evaluation of the PET-CT scans was based on the PERSIST criteria, and tumor response was classified as complete metabolic response or residual disease. On the follow-up PET-CT scans, each region was classified as either no change, resolved nodes, or new nodes. Okay, then only the complete metabolic resolution of all disease, so nodes outside of the radiation field, nodes inside the radiation field, and the tumor, as visualized on the post-treatment PET-CT, was considered to be an indicator of the abscopal effect. As I mentioned previously, 210 participants were randomized for treatment, of which 146 participants had FDG avid extrapelvic nodal disease, visualized on the pre-treatment PET-CT scans. Of these 146, 108 participants with extrapelvic nodal disease also had post-treatment PET-CT scans. 54 of these participants were in the control group and 54 in the mEHT group. Okay, these 108 participants were therefore included in the analysis. As you can see in this table, there were no significant differences in the characteristics of the patients. Okay, the following graph, there we go, also shows, this illustrates the number of participants divided by a treatment group as well as HIV status, and it shows the number of participants with nodes in each region. And again, you can see that there's no significant difference between all the groups. Okay, and again, the treatment characteristics. In this table, you can see that there aren't any significant differences between the groups. Okay, so now onto the exciting part. The percentage of participants with complete resolution of all metabolically active disease, even outside the treatment field at 6 months, was significantly higher in the mEHT group compared to the control group, with 24.1% compared to 5.6%, which is 13 and 3 participants. So this result is quite significant. But what was interesting is that when we analyzed these participants based on HIV status, there was no significant difference in the response between the HIV positive and the HIV negative participants. So this suggests the potential that the potential immune stimulation was happening even in the potentially immunocompromised participants. Then we also looked at variables, and in a multivariate analysis, we considered age, the number of cisplatin doses, the total radiation dose, days between the last radiation and PET-CT. And none of the variables were associated with an abscopal response. And a univariate analysis of the CD4 count also showed that the CD4 count was not predictive of an abscopal effect. Okay, we are continuing to follow up these participants. Two participants in the mEHT group and one in the control group demised before 2 years post-treatment. The cause of death was acute renal failure. However, 7 participants in the mEHT group and the 2 in the control group are disease-free and alive at 2 years post-treatment. The other 4 participants in the mEHT group haven't yet reached 2 years post-treatment, but they are still alive and disease-free. Then we also conducted a thorough analysis of the relationship of the nodal positivity and the HIV status of the participants. And this was published elsewhere. And this indicated that the nodes that we visualized in this analysis were indeed from due to metastatic disease and were not likely to be reactive in response to HIV infection. In an interesting case, one participant in the mEHT group had visceral tumors, visceral disease on the pre-treatment 18-FDG PET-CT scan. She had multiple lung nodules and a lesion on the T11 vertebra. What happened was a delay in the PET-CT reporting from the nuclear medicine department meant that the participant was randomized and started treatment before the report was complete. So she continued through treatment and we continued to follow her. This participant is 24 months post-treatment and is still alive and disease-free. And her 6 months post-treatment PET-CT scan showed no sign of metabolically active disease. So our conclusions are that the complete metabolic response of disease outside of the radiation field provides evidence of an abscopal effect. We further concluded that the frequency of the observed abscopal effect was significantly associated with the addition of modulated electrohypothermia. So, several murine models have shown the potential for immunotherapies to enhance the abscopal effect when combined with ionizing radiation. However, murine models have also demonstrated the potential for immunotherapies combined with mEHT to stimulate an immune response against non-treated lesions. For example, there we go. Vangsik and colleagues showed that mEHT combined with T cell stimulators induced damps in murine models, and that this led to the invasion of antigen-producing cells and T cells at the treated tumor as well as in the untreated tumors in the same murine model. And then Kin and colleagues showed that mEHT combined with dendritic cell therapy elicited a response to untreated tumors in murine squamous cell carcinoma models. Okay, ionizing radiation also increases the expression of certain DAMPs, such as calreticulin. And another molecule which plays a role in mounting the immune response when released into the extracellular matrix is heat shock protein 70. mEHT has been shown to stimulate the release of expressed HSP70 and of calreticulin. So these, as well as other mechanisms, are potential contributors to the mounting of an immune response to tumors treated with mEHT. Okay, these results are strong motivators for the development of clinical trials on mEHT, radiotherapy, and immunotherapies combined. This finding is important as methods to enhance the abscopal effect could broaden the scope of ionizing radiation from a local treatment to a systemic treatment, and from palliative treatments to a potentially curative treatment. So I'd like to acknowledge our funders, as well as Oncotherm for supplying the device, and thank you to all of the staff involved at various aspects of the patient's treatments, as well as the patients themselves, without whom none of this would have been possible. And finally, thank you to the organizers of this conference for the honor of being able to present our results, and thank you to each and every one of you attending and listening to the presentation. I wish you a successful conference, and I hope that you all remain safe and healthy.